Okay, thank you very much to Apostle for inviting me. I'm pleased to give you this talk on approach to prevent and reverse cirrhotic cardiomyopathy. Now, before I go into this talk, I want to say that what makes this talk interesting is that really it is at the verge of two important specialties. You've got gastro, but you've also got cardiology. And so I think that it's important to introduce, for many of you here, some cardiology principles so we can better really define what this is that we're talking about. So, a very simple definition is that cirrhotic cardiomyopathy is cardiac dysfunction in end-stage liver disease in the absence of prior heart disease. So this is a very simple definition, but as I will show you, there have been a number of definitions that have been floating around about this condition, and these definitions keep changing. We know, and this is well known, what happens to the heart in cirrhosis. We know that certainly if you've got decompensated disease, there are significant physiological interactions with the heart and the circulatory system. Those that have cirrhosis and portal hypertension, they often get this hyperdynamic circulation. We know there's increased intrahepatic vascular resistance, which is due to fibrogenesis. We know that there is this process, and I'm sure that you're aware of this, activation of the neurohumoral mechanisms, the renin-angiotensin system, the sympathetic activation, and of course this is going to lead to increased circulatory stroke volume. It's going to lead to increased heart rate, increased cardiac output. We'll talk about these important concepts, preload and afterload, simple definitions, but certainly for preload, that's an initial stretching of the cardiac muscles prior to contraction. It is related to ventricular filling, and it's really relevant when it comes to cirrhosis because we know that there's an increasing circulatory blood volume in cirrhosis, and that leads to a high cardiac preload. It's different when it comes to afterload. So that's the force which the heart is actually having to contract against to eject the blood. That afterload goes down in cirrhosis because of decreased systemic vascular resistance, because of vasodilatation. So these are some important principles here. Now, in systole, which is that phase of the heart where we see the ejection of blood from the ventricles, we know that ejection fraction is very important. So that's the measurement in a percentage of how much blood the left ventricle pumps out with each contraction. So if you've got an ejection fraction of 60%, that means that 60% of the total amount of blood in the left ventricle is pushed out with each heartbeat. Now, what is normal left ventricular ejection fraction? Depends on the different societies. The European Society of Cardiology says it's more than 50%. The American Society of Echocardiography says it's 55%. We know that most of the trials for heart failure have said 40 to 45% indicates left ventricular systolic dysfunction. But we also know that if you've got a left ventricular ejection fraction of between 50 to 55%, that is not normal. They do have a greater risk of morbidity and mortality, and so therefore it's useful to address those that have a left ventricular ejection fraction of less than 55%. I'll also mention that ejection fraction is very dependent on loading conditions. So in cirrhosis, we know that the majority of patients actually do have a normal resting ejection fraction. And this means that it's quite difficult then to identify early if there's a problem in systolic impairment in these patients. So this introduces a new concept, a concept of what we call myocardial strain. And this is the idea, and certainly when you do an echocardiography study, you find that on 2D echo, there's often radial strains. So there's a strain which is noted upon systole. But what we're realizing is it's not just radial, it's a number of different dimensions, circumferential and longitudinal. We can see here that you can often create these little charts here where we can see evidence of myocardial, what we call deformation strain. So this is somebody who has, let's see if I can point it out here. Maybe not. So the 1A is a normal strain plot, whereas you can see that B certainly is not. And E, if you look at it, it's very obvious that there's this apical strain which is present there. There's reduced strain in that apical segment. Now, this is quite important. So the idea of global longitudinal strain has been introduced in cardiology. And this is important because we can now use a non-ejection fraction measure to identify systolic dysfunction early, because we know that longitudinal contraction is impaired before radial contraction. And so we can identify, using this measure of global longitudinal strain, an early marker of systolic dysfunction. And this has actually been a revolutionary concept in cardiology over the past 10 to 15 years. We know that less than 16%, if you do this metric, global longitudinal strain, is abnormal, whereas 16 to 18% is borderline, and more than 18% is considered to be normal, and this is expressed as a negative number. So that's an important concept. Diastole. So what happens here after the heart relaxes and the ventricle is starting to fill with blood? Well, we know that there are some important changes that are occurring. There's these two waves that you should know about, an E wave and an A wave. So in the heart, as we can see here, with the left ventricle, what happens is that during filling, most of the blood enters the left ventricle very quickly. So it's entering very quickly during early diastole, and that creates a wave called the E wave, whereas later on you get this A wave that's caused by atrial contraction. And in the vast majority of people, certainly normal patients, will find the E wave greater than the A wave. Now, here's another important point, and it comes from an advance that's happened in cardiology over the last 15 years, something called tissue Doppler imaging. And that basically is we can look at tissue, myocardial tissue, and we can work out what's occurring. You can see here that if you look at the middle diagram there with the left ventricle, you've got this mitral valve annulus. And so blood is rushing into the left ventricle, so rushing in quite a rate, but at the same time, the mitral valve annulus is moving back up. So there's a kind of a recoil, if you imagine. Now, if there's a lot of pressure in the left atrium, then what happens is that the recoil back, what we call E prime, is going to be quite slow. It makes sense, wouldn't it? If there's a lot of pressure up there, it's going to be slow going back up, whereas E could be quite forceful. And so we can actually now look at a ratio of E over E prime, and that is going to be, as we'll explain later on, an important metric for diastolic dysfunction. Now, here's what happens in normal echo. So we can see here, this is a normal person. So young subject, we have the E and the A wave, so in the middle frame there. And we can see that also you've got your E prime down below on my left-hand image there. And we can actually see some of those metrics here. So we can see that E, for example, the E to A ratio is greater than 1. Clearly E is bigger than A. And over there, you can see that the E prime, we can use, that's a lateral, what we call a lateral E prime velocity, is actually quite good. It's 12 centimeter a second. It's quite quick. We want that to be ordinarily fast, because if it's rapid and back up, it means there's not a lot of left atrial pressure. So this is important. The reason why all this is important is that the EA ratio is very affected by loading conditions. So that in cirrhosis, in particular, the EA ratio is not always the best measure. And that's because you get a lot of blood pooling in the splanchnic bed. You often get reduced preload, and that can result in low EA ratios, irrespective of what's going on in the heart. But the E prime, which we can see there, that is relatively preload independent. So that's actually important. It reflects the status of myocardial relaxation. Okay, and I'll go to the next slide. The tricuspid regurgitation velocity is another important measure. So it's a measure of what we call diastolic dysfunction. But we can also use it in pulmonary hypertension. There's some caveats there as well, because you can't often tell between pulmonary venous versus pulmonary arterial hypertension, and therefore some conditions like portopulmonary hypertension, it can be elevated in the absence of elevated left ventricular filling pressures. So just something to be aware of. So just incorporating those measures that we've just talked about already, you can see here that diastolic dysfunction is understood as impaired left ventricular relaxation with increased stiffness of the left ventricle and elevated left ventricular filling pressures. And we talked before about some of these important metrics that, we talked about the E to A, which is on your left-hand side here. In the middle, we talked about the importance of E prime, and then you look at the tricuspid regurgitation velocity. And the reason why all this is important is because and one other final metric I'll talk about here, which is the left atrial volume index, or LAVI. So the American Society of Echocardiography says that LAVI is actually a good measure of left atrial pressure, and it is the value of the left atrial volume divided by the body surface area. So we can actually get this index based upon your body surface area. So now we can define, and this is why I want to come back to cirrhotic cardiomyopathy here, we can define diastolic dysfunction. And it's largely thanks to the advent of technologies such as tissue Doppler imaging that's come about, as I said, in the last 15 years. So someone who's got normal left ventricular ejection fraction, these are considered to be what we call abnormal measures. So if your E to E prime is more than 14, okay, that means that your E prime almost certainly is going to be very low. For that ratio to be very high, the denominator has to be quite low. So you can see here the septal E velocity and the lateral velocity. So these are two E prime. The lateral is always greater than the septal one. They're very low. So remember I talked before about that recall back into the left atrium. That's where the velocities are low. The tricuspid regurgitation velocity is quite rapid, more than 2.8 meter per second, and the LAVI, or the left atrial volume index, more than 34 mils per meter squared. And so what they've defined here is that if you have certainly 3 or 4 of these, that person has diastolic dysfunction. So a good example, so that this is all becoming very clear to you all, we can actually look at this example here. So we can see that this is somebody who has an E to A ratio, which is certainly greater than 1. This is the middle one, the middle image, top middle image there, E prime. We can see that that's your septal one, which is about 4 centimeters a second. The one on the right is about 8. So average it out, you get about 6 centimeters a second. So if you want to work that out, the E, whatever, there's about 1.4, the top, divided by 0.006, so it's about, remember, so that's 6 centimeters a second, which is 0.06 meter per second, and you get a large figure, 23.3, which is greater than 14, and the tricuspid regurgitation velocity down below is 3.4 meter a second. So this is somebody you can see already has got diastolic dysfunction. And certainly, based upon those measures, yep, evidence of diastolic dysfunction. Now that person had normal left ventricular ejection fraction. What if they had a decreased one? So really nothing much changes except for that EA ratio. So you see that there? The EA ratio is actually quite high. It's 1.4 divided by around there, 0.5. So it's about 2.8. So if you look at the same sorts of measures here, again, same sorts of criteria, but here the EA ratio is very high, and that person has a more advanced form of diastolic dysfunction, a grade 3 diastolic dysfunction. Okay, so getting back to this now, and about cirrhotic cardiomyopathy, where we know that this is a condition that is difficult in many ways to research because it requires, the collaboration between a number, as I said here, of different specialties. But what we know about it is that there's a component of both systolic and diastolic dysfunction. There's probably evidence of fibrosis happening here, but there's also a number of other changes, probably some interstitial edema, hypertrophy, which is occurring. We know from some newer technologies, and this is the use of cardiac MRI T1 mapping, that we can look at a concept called myocardial extracellular volume, We can see that here on my left, furthest left here is a normal myocardium with a normal ECV. And over here, diffuse myocardial fibrosis in red here. So you can see the ECV is a lot higher. And the reason why this is important, when we look at the histology of these patients, certainly there's a lot of fibrosis which is occurring, and probably edema as well. And this has been shown from some studies, so certainly autopsies, that in cirrhotic cardiomyopathy, swelling myocytes, altered collagen composition, interstitial fibrosis. We know that there is a relationship between that myocardial ECV and a high cardiac index and increased plasma renin levels. So this is all tied in together. And interesting enough, as we'll explore here, there's a relationship between increased myocardial ECV in cirrhosis and disease severity and poor transplant-free survival. Look at this study here. Myocardial extracellular volume quantified by magnetic resonance is increased in cirrhosis related to poor outcome. We know that when you divide by Child-Pugh scores here, that certainly the myocardial ECV percentage is increased in those that have a high Child-Pugh score. But importantly, if you were to stratify the myocardial ECV and use a cutoff at, say, 31.2%, you can work out there's a significant difference between transplant-free survival in patients with cirrhosis. So myocardial extracellular volume is an important metric here. So, getting back to it all, the original definition for cirrhotic cardiomyopathy was the World Congress of Gastroenterology criteria in 2005. And they used these terms: systolic dysfunction, so blunted contractile response and stress testing. What does that mean? It means if you give them a stress response, like dobutamine, you get a very blunted response. Left ventricular ejection fraction of less than 55%, which I think is reasonable, given that anything below 55, we know from some data, is probably not normal. Diastolic dysfunction, again, they looked at the EA ratio of less than 1, so in other words, you had a very high A wave compared to an E wave, and used some other metrics too, which is the deceleration time, and that really refers to how rapidly the flow velocity declines in early diastole, and the isovolumetric relaxation time was really how long it takes for the ventricle to start after the ventricle relaxes, so that feeling to start. And these are a number of other supportive criteria. If you have, for example, a prolonged QT interval on ECG, enlarged left atrium, these are sort of very loosely defined criteria. But that criteria, this is old, because as I've said to you, with some of the new technology we have now, this has transformed our entire definition of cirrhotic cardiomyopathy. This is what the Cirrhotic Cardiomyopathy Consortium has proposed now as the new definition. With systolic dysfunction, they've said left ventricular ejection fraction of less than 50%. Look, I would probably disagree with that. I think less than 55 is more reasonable, given that we know that 50 to 55% isn't quite normal. But they've used now the term fortunately, of global longitudinal strain. So they use that particular metric. They've actually gone back to using the diastolic measures that I've referred to you before. So those same measures, now incorporating the information with tissue Doppler imaging and looking at E prime importantly has been very helpful. And look, there's some areas which they think need further validation, like cardiac MRI scans. So they've recommended that in waitlist candidates, echoes should be done at 6-month intervals at 6, 12, and also 6, 12, and 24 months post-transplant to identify those patients where you may have worse outcomes. And interestingly enough, they also feel that early interventions will be useful, targeting to blood pressure. Now, I want to talk quickly about liver transplantation, because most people would think, well, liver transplant's done, it somehow miraculously improves cirrhotic cardiomyopathy, but that's actually not the case. We know that liver transplantation does improve peripheral vascular resistance and blood pressure, so that's increasing both your cardiac preload and your afterload. In patients that have cirrhotic cardiomyopathy, that can lead to overt cardiac failure and pulmonary edema. We do know that their hyperdynamic circulation improves and that some of the autonomic function improves as well. The QTc prolongation definitely improves, so that's advantageous. But we also know that as I mentioned before, with cirrhotic cardiomyopathy, there's this increased left ventricular stiffness, and that's probably from a combination of factors: hypertrophy, fibrosis, subendothelial edema. And it's unclear whether after transplantation, particularly if it's been long-standing, whether some of that changes. So if it's fibrotic, it's less likely to change compared to, say, edema, which does improve. Now, this unfavorable impact of cirrhotic cardiomyopathy, you can see it here, where study by Middle and colleagues did 970 transplant patients, evaluated them for a mean of 5.3 years. They found that 15% of these patients had diastolic dysfunction pre-transplant, and these patients were found to have a significantly higher risk of acute cellular rejection, graft failure, and all-cause mortality. And they found the risk got worse with a worsening degree of diastolic dysfunction. Now, it's not exactly clear why that diastolic dysfunction should be associated with, increased allograft rejection, graft failure, but some speculated it may be due to upregulation of pro-inflammatory cytokines, and maybe the elevated venous pressures are resulting in decreased clearance of these pro-inflammatory cytokines. The final thing I want to talk about, and it's an important one relating to what was covered earlier, it was a concept of targeted heart rate reduction. So certainly in cardiology, this has been a very important principle, and that is the idea that you can treat left ventricular diastolic dysfunction by reducing preload through nitrates and by ameliorating neurohumoral activation. So if you lower the heart rate to 55 to 65, and some would say 55 to 60, but certainly if you lower with beta blockers, that's going to improve myocardial oxygen demand and coronary perfusion. We also know that certainly in all the cardiology studies with heart failure, targeted heart rate reduction has reduced mortality. Now, this is a study that was looked at. This is like the first randomized control study to look at the efficacy of beta blockers in non-alcohol related cirrhotic cardiomyopathy. And what it did show was that metoprolol succinate, which is studied here in patients with cirrhosis and impaired systolic reserve, it didn't actually improve their left ventricular systolic volume, and it didn't improve their left ventricular volume, didn't improve diameters or ejection fraction. And in fact, it really didn't do much. I mean, they even looked at troponin levels, plasma renin, and they found there was really no difference between those that were using metoprolol and those that weren't. So it didn't really show any benefit of using metoprolol specifically for this condition. However, we've talked before from a number of speakers about carvedilol, and this is interesting. So this is a study from Sinha and colleagues, and they want to look at long-term low-dose carvedilol therapy. And I just want to say and really emphasize the importance of what was mentioned before about carvedilol, that certainly it is a different kind of beta blocker. It's got an alpha-1 effect as well, more effective than propranolol, certainly in reducing portal pressure. And what we found in this study of looking at 264 patients with cirrhosis and ascites was that they used a very low treatment dose of 12.5 milligrams. So that's a dose that can reduce portal pressure, and here's a very important point, does not alter the mean arterial pressure. So really important point, and I'm going to come back to this. In this study, the reduced carvedilol dose reduced the risk of death over a median duration of 49 months. And in fact, the survival at 1 year was 78% for carvedilol and 65% for non-carvedilol. So interesting. So this paper is where it gets interesting. So carvedilol and ivabradine in cirrhotic cardiomyopathy. Now, ivabradine, some of you may have heard of, is quite a new drug. It's a drug that's used for treatment of heart failure. And you can use it in combination with other drugs like beta blockers. So in this particular study, which was done from a group from New Delhi, they found that their aim was to assess the effects of targeted heart rate reduction with either beta blocker alone, carvedilol, or in combination with ivabradine on left ventricular diastolic dysfunction. So that was what they were looking at specifically for, and we know that left ventricular diastolic dysfunction is an important metric in cirrhotic cardiomyopathy. They looked at these patients very carefully over a year. I'm going to come into, I'll go into this with a bit more detail. Now, what they found here was that that patients with cirrhosis and eradicated esophageal varices were actually screened for between 2 years and included this prospective open-label randomized controlled trial. They were aged between 18 and 65. They had eradicated esophageal varices, so this is secondary prophylaxis, and they had to have left ventricular diastolic dysfunction on echocardiography. And so they defined those same measures that what we saw before, exactly the same, grade 1, 2, and 3 diastolic dysfunction, and they diagnosed if he found systolic or diastolic dysfunction together with some supportive criteria like ECG abnormalities or abnormal serum markers. There were a lot of exclusion criteria, so it's really relevant to note that there's a lot of exclusion criteria here. And I guess one of the most important ones is hypertension. So people that were already on drugs to lower their blood pressure were excluded from this. Now, they had the definitions for cirrhosis, which I won't go into, but eradication of varices was defined as no residual varices or only grade 1 varices. And this is sensible because you needed to have those that had eradicated varices if you're going to randomize them and not give them any kind of beta blocker. Now, targeted heart rate reduction is defined in their study, 55 to 65 beats per minute. In portal hypertension, we know that obviously a non-selective beta blocker is titrated against their heart rate, but they use that criterion. This is the consort flow diagram for the study. And what we can see here is that of 189 recruited patients, there's about 148, so almost 80% that met criteria for cirrhotic cardiomyopathy at baseline. There were two groups, A and B. So group B had standard medical therapy with dietary modifications. They had like lactulose, they had rifaximin, those that had prior encephalopathy, and they're also on a surveillance program for endoscopic variceal ligation. They were not on any antihypertensives. Whereas in group A, they were randomized to carvedilol at a starting dose of 3.125 milligrams twice daily with weekly titration to a maximal dose of 12.5 milligrams twice daily. So that was a maximal dose, and they had to make sure that there weren't any side effects like hypotension or bronchospasm. And they found that those that had carvedilol that were able to achieve their targeted heart rate, they called them A1, as you can see there. Those that didn't achieve their targeted heart rate, they actually started them on ivabradine in addition to the carvedilol, and they started ivabradine 2.5 milligrams twice daily, and they got to the maximum 7.5. So we can see that looking at the chart here, that the carvedilol median dose was about 9, and the ivabradine dose was about 7.5 altogether. And that was considered reasonable because it didn't affect, again, their mean arterial pressure. So when we look at the results here of this study, and as I said, I'll be finishing shortly, but if we look at the heart rate reduction after about a year of treatment, we can see that certainly the use of beta blocker and ivabradine was more effective in achieving a targeted heart rate reduction compared to standard medical therapy. The next slide, very important here, there is no change in mean arterial pressure between the groups here, carvedilol and ivabradine, and standard medical treatment. But there was a difference in diastolic dysfunction. So we know that a responder to total heart rate reduction resulted in a 0.68% decline in that E to E prime ratio with carvedilol alone, and a 10.8% decline with a combination of carvedilol and ivabradine. But in contrast, there was a 14.6% increase in that E to E prime ratio in that group B. You can see there. So this is actually very interesting. Now, does that combination, does carvedilol and ivabradine make a difference to outcomes? I would argue yes. They looked at some of those measures and they found, you can look at those findings there, but certainly it does make a difference to a lot of those outcomes. There are a lot of significant findings that we can see. And when they looked at the mortality, so they looked into on bivariate analysis MELD and MELD sodium, which I'm sure many of you are aware of. That's where you incorporate MELD and sodium because some of the patients with cirrhosis and hypernatremia have a worse mortality compared to those with normal sodium levels. That MELD and MELD sodium was found in bivariate and multivariate analysis to, of course, be related to mortality, which is not surprising. But what is very interesting is that E to E prime ratio, that is related to mortality, even on multivariate analysis. So very important there. And when we look at the survival here, as I'm coming to the end here, but survival over 1 year for all subjects. So they followed out to a median of about 18 months. And what they found was that, look, there was certainly a difference between those that had been using beta blockers. In fact, when you look at the top group here, the carvedilol and vabradine, surprisingly, there's actually no mortality seen in that group, even up to about 24 months. And that might just be coincidental. But certainly the measures are superior when you use a beta blocker or vabradine compared to standard medical treatment. So take-home messages here. There's been significant changes in echocardiography, particularly with tissue Doppler and myocardial deformation imaging. And I think we need to look at that revised definition. I think it's appropriate that things have changed a lot since 2005. It's often believed that CCM improves after liver transplantation, but there's no real data to support this. And in fact, diastolic dysfunction may not improve post-transplant and can actually, in some cases, be worse. We know that targeted heart rate reduction to 55 to 65 beats a minute can reduce preload, been shown to improve diastolic dysfunction and ameliorate neurohumoral activation. Important that it does not affect your mean arterial pressure, as a number of speakers have commented previously. And so we know that carvedilol, with or without vabradine, has been shown to reduce clinical adverse events and improve survival in cirrhotic cardiomyopathy. Thank you.